Okay, let's get started. Welcome everybody to this week's Miami Global Brain Tumor Symposium. My name is Michael Ivan. Just some quick introductions before we get to tonight's presentation. I'm the director of this seminar and also director of our brain tumor research program. I'm a skull-based and brain tumor specialist here at the University of Miami, and I'm joined today by my co-directors, Dr. Benjamin, who's joining us from the OR, assistant professor, director of our skull-based laboratory, and a brain tumor skull-based specialist. Dr. Morcos, who's professor and co-chairman of our department, director of our cerebrovascular skull-based program, and Dr. Komatar, professor and program director of the UMBTI and our residency program. Thank you for joining us. Each week we put this on. This is our 37th symposium since COVID started, and I can't do it without the support of Sylvester Comprehensive Cancer Center, University of Miami, and the Department of Neurosurgery, and it's these special people each week that help us out put these on. So thank you so much. For any questions about tonight's talk, or if you want to get in touch with us, or if you want to watch the broadcast again, you could always follow us on social media where we post all the information, specifically on our YouTube channel where all of the symposiums that we have monthly are posted, both for the brain tumor symposium, skull-based, and pediatrics and vascular. And that brings us to just a couple announcements. So, our symposium now for brain tumors is the first Wednesday of every month, and it's on a monthly schedule. And we also have two other symposiums, the pediatric neurosurgery symposium. This is an old flyer here, but that's going to be on Mondays, the second Monday of every month. So stay tuned for the upcoming one. And then Dr. Morcos has the cerebrovascular and skull-based one, which is the third Thursday of every month, and this month will be exceptional, just like every other month, talking about aneurysms, looking at web, FDD, and clips with a great group of very, very experienced professors from around the country. So please stay tuned. It's going to be June 17th from 5 to 7. Next month, we have an extra special guest coming from Canada. Dr. Rudka, I think, is very well known. No introduction is needed. He's going to be talking about his experience over the many years of brainstem tumors and what the future directions may hold for these, both surgically and non-surgically. So please stay tuned for next month. But let's talk quickly about this week. So first, some housekeeping. We try to make this as interactive as possible, so please use the Q&A button to ask your questions, and the panelists will help kind of answer those along the way, as well as get to them at the end of our speaker. We don't offer CME, but you can get email confirmation documenting your participation, and please be sure to like, follow, and share our videos on YouTube, as well as our posting on Instagram and Twitter, so we continue to share this free material around the world with everybody who's interested in brain tumors. This week, we have a great group of panelists. Dr. Zachariah is joining us from Penn State. Brad has a long history of experience of research with glioblastomas from his time as a resident at Columbia University, and is now just continuing great success at Penn State. He's a co-director of their neuro-oncology program and director of their brain tumor and skull-based program. And Alexa, who I know personally, now a resident at UCSF, was here just a short while ago at University of Miami as an NREF brain tumor fellow working with us in the brain tumor laboratory. We'll discuss a little bit about some of what we've discussed in PDT and gliomas and looked at in the laboratory as well. But tonight we have a very special guest joining us late night all the way from France, and Dr. Nicholas Renz, who is a professor of neurosurgery at the University of Lille. He joins us at 11 p.m. So thank you so much for joining us late in Europe to share really such a unique experience that you've built over the last decade with PDT and gliomas. He continues really to lead the way in not only development, but also in the use of photodynamic therapy. He's already completed his phase 1 clinical trial, and I'm sure he'll share with us tonight about that, and has already started the phase 2 clinical trial, really the only one in the world that has done that. He's published more than 125 papers on brain tumor outcomes and research, and he's a key investigator at the Oncotai image-assisted laser therapies for oncology at the University of Lille, as well as a medical advisor for Hemarin Therapeutics. So we thank him again so much for taking the time out of his week to join us and share with us his unique perspective on this disease.
So thank you very much for giving me the opportunity to share with you our experience with PDT in the management of glioblastoma. So I have to disclose my relationship, with Emerald Therapeutics as a co-founder and medical advisor. So our university hospital is located in north of France and cover 4 million people population. So considering the incidence of GBM or glioblastoma, we have to manage around 180 glioblastoma each year. 2/3 of them are surgically removed. In the way to improve the local control of this tumor, we started the fluor-guided surgery in 2012. We have been using an intraoperative MRI since 2014 and started a research program about 5LA photodynamic therapy in the brain with Preclinical Studies in 2012, prior to a first clinical trial, Indigo, in 2017 and 2018. We are now close to start a new clinical trial, Dose Indigo. So the local control of this tumor is still an issue, considering that their relapse occur in most of cases in the 25 millimeters around the surgical cavity. It's indeed the goal of a surgical strategy as FGS using accumulation of a PP9 in malignant cell, being fluorescent under blue light, and also the goal of intraoperative MRI had this platform we use since 2014. But this technique may improve PFS, but their impact on OS is still highly questionable. The rationale of intraoperative PDT is indeed based on this way of recurrence of glioblastoma around the cavity. In most of cases, it aims to treat the remaining cells in the surgical cavity borders. First, I would like to clearly define what is photodynamic therapy for those of you who are not friendly with the technique. PDT is a therapy consisting of the lightning at a specific wavelength by lasers or diodes of sensibilized tumor cells by pharmacological agents, the photosensitizer, the PS, okay? So this technique requires the administration of a drug as a photosensitizing agent, PS, before the light exposure of malignant cells at a wavelength corresponding to the absorbance band of the PS. The combination of PS, light, and oxygen achieves a photochemical reaction leading to the production of reactive oxygen species, the so-called singlet oxygen. And this latter leads to a specific cytotoxic effect through necrosis and apoptosis. Well, we have to keep in mind that PDT emerged in the late 80s as a promising technique for the management of numerous cancers, but it did not arise in the standard of care of brain tumors, although it has been achieved with encouraging results in the treatment of glioblastoma in many patients. Probably that the toxicity of the first photosensitizer, the cost of the technical means of elimination, and the need of human resources can explain the difficulty of its implementation. Well, I actually recommend this review about photodynamic therapy in the case of many cancers. But the improvement of pharmacological and technical means, as medical lasers or diffusing fibers, over the last decades make it possible to foresee the implementation of PDT in better condition. So about lasers, look at the size and weight of 1 watt laser in the 80s and how it was in 2014 compared to this well-known reference. This miniaturization facilitates the implementation of these lasers in the operative theater. So light diffusers also improved, but PS also improved indeed. Remember that 5LA is an endogenous amino acid. This is a precursor of the PP9, protoporphyrin 9, and PP9 is a true PS, okay? 5LA is a precursor, is a prodrug, and the accumulation in the malignant cells of the PS is by PP9 because of enzymatic deficit blocking its integration in the M synthesis. So look at the light spectrum of PP9. There is a peak of absorption at 400 nanometers, so indeed the blue light, allowing the photodiagnosis and FGAs. There is another peak of absorption around 635 nanometers, penetrating deeper with higher energy leading to PDT. Okay, so keep in mind that PDD and PDT are the same photochemical reaction. So PP9 is a PS suitable for both FGAs and PDT, selective for malignant cells with low toxicity for the brain and also for the skin. So it's very convenient for this kind of indication. Another cause of the limitation of PDT is also probably the lack of standardization, since existing clinical studies generally use different photosensitizers, different illumination modalities. And in these studies, the Japanese team using chlorine as PS and semiconductor lasers for illumination, while this one, the team of Walker's tumor, only for recurrent glioblastoma, use 5LA and as PS and cylindrical laser diffuser. So at the end, these studies have not allowed the best PT protocols to be defined, leading to the lack of clinical trials evaluating its effectiveness. So I also recommend this recent review, this nice review about 5LA photodynamic therapy by the team of Costas and Gipanais. And I agree with the conclusion of this paper, since even prior studies highlight potential efficacy of PDT in the management of GBM, the uncontrolled nature of this study with small number of patients, the heterogeneity of these studies in terms of design, adjuvant therapy, tumor subtypes or diagnosis, and the technical heterogeneity about dose-like PS or method of light application don't let us know if there is an additional benefit of PDT in comparison with the standard of care. And we never know it until the PDT will reach the point of control phase 3 study. So we have been conducting preclinical studies since 2012 for a better understanding of relative contribution of the mechanisms involved in PDT. Okay, I will be brief about preclinical study that are published now. Just to let you know that our clinical trial did not arise from nowhere. So for preclinical study, we use this rodent model of U87 glioblastoma and grafting stereotactically U87 cells into a brain of rats. And the tumor growth was assessed by this 7 Tesla MRI dedicated to small animals. So during the first preclinical study in 2014, an animal model of interstitial 5LA PDT of U87 glioblastoma was validated. The tumor was photosensitized by intraperitoneal administration of 5LA. Elimination of the tumor was achieved through an MRI-guided optical fiber here, and light was delivered from a 635 nanometer diode laser. So in this model, we obtain a histologic effect with a dose of 25 joules per square centimeter. And moreover, this model validated the effect of 5LA PDT was clearly related to the light delivery condition, since 5LA PDT induced greater necrosis during fractionated administration with a high fluorescence rate. So in a second phase of our preclinical studies, we compared 2 fractionated and 5 fractionated light schemes. The total delivered dose was 25 joules and at a high fluorescence rate of 30 milliwatt per square centimeter. So the 5 fractionated scheme induced greater tumor necrosis and apoptosis, but formed also more important perizonal edema. Here is an illustration of apoptotic bodies in the tumor after a 5LA PDT. So during a third preclinical study, low power PDT response was monitored by 5 Tesla MRI examination and compared with the previous MRI data acquired during the previous high power PDT study. The 5 fraction group at 5 milliwatts by square centimeter was associated with a significantly lower level of edema, but had no significant difference from the other treated group in terms of cell death, characterized by diffusion imaging or in terms of necrosis level. But it was well, much more tolerated. So based on these preclinical studies, we aim to develop an optimized and reproducible 5LA intraoperative PDT protocol for the management of newly diagnosed glioblastoma with a dedicated medical device that will facilitate further multicentral controlled clinical trials. So we designed the clinical trial INDIGO to evaluate INDIGO for intraoperative dynamic phototherapy, to evaluate mainly the safety and relevance of intraoperative 5LA PDT using our medical device after FGAs, repurposing the drug currently used in photodiagnosis. For sure, we also aim to evaluate the PFS, OS, quality of life, and a possible immune response induced by PDT. So we position the PDT intraoperatively as an add-on technique without modifying the standard of care in the way to treat the walls of the surgical cavity, so that it will be further possible to evaluate the clinical benefit of added PDT to the standard of care alone. This clinical trial was an interventional pilot study. We achieved the enrollment of 10 patients over a period of 12 months. This patient presented with probable newly diagnosed glioblastoma based on clinical and radiological criteria, and in whom gross total resection was achievable. The main exclusion criteria was a contraindication to 5LA or MRI procedures. So the design of the study consisted in fluorescence guided surgery performed after 5LA, orally administered at least 6 hours before the surgery. An intraoperative PDT was performed before, intraoperative MRI was performed when there was no remaining fluorescence to assess the quality of resection. Then the intraoperative PDT was performed before second intraoperative MRI to exclude any potential early treatment toxicity. So we use 5LA to see the tumor during an FGS procedure under blue light and to treat by PDT under red light to achieve the so-called 2-3 and to treat strategy. So the illumination of the cavity remains an issue since the device must be suitable for the volume of the cavity. So we thought that an inflatable balloon would be suitable. We developed then a new device dedicated to intraoperative PDT, delivered immediately after FGS and designed to be commercially available. This device is composed of a trocar, a balloon filled with a diffusing solution and a fiber guide in which a signal light diffuser was inserted. So this diffusion solution allows a strong diffusion indeed of the laser light and enables increased homogeneity of the light emitted from the source. Before, ex vivo experiments were performed on calf brains to determine a transfer function to define easily the duration of illumination from the volume of diffusing solution injected to inflate the balloon in the surgical cavity. So we could overcome dosimetry pitfalls due to the variability of the surgical cavity volume. And this device is then a kind of user interface allowing integrated dosimetry during the surgery time. So here is an abacus allowing an automatically computed light duration illumination during the surgery. So the laser light exposure during the PDT procedure was achieved by means of a dedicated illumination device connected to a 3-watt laser system. Indeed, so transponding the notion of high and low energy achieved in our preclinical study to human was indeed highly challenging and not really achieved. But the illumination duration was then automatically computed for the quantity of diffusing liquid injected in the device, so that the cavity wall received 200 joule per square centimeter just on the surface of the balloon. The treatment sequence was composed of 5 illumination divided by lightning break in order to reoxygenate brain tissue, as evaluated in preclinical experiments. So those data now are published, and the clinical follow-up included clinical examination and brain MRI imaging before surgery, before and after PDT, post-operatively, then every 3 months until tumor progression and or death, as usually in the clinical follow-up of glioblastoma. And immunomonitoring was performed. Well, these data are close to be published, and I won't disclose clearly these results. The population of the study was quite representative of patients presenting with glioblastoma, with a median age of 66, 56, sex ratio in favor of men, and a ratio methylated in favor of unmethylated tumor. Important data, I think, is the additional surgery time was acceptable for this kind of surgery, with a median of 35 minutes. And so this additional surgery time was related to total illumination time, and the device setting duration. Since during this first trial, the device had to be assembled during the surgery. Indeed, Emerald Therapeutics is actually working on a disposable device to simplify the procedure. So, and here you have an idea of the volume of the cavity treated. At the time I speak to you, 6 patient deceased, 3 of them had a recurrence in the operative field, and the other distant from the operative field. 4 patients are still monitored. 1 patient relapsed and had a second surgery with carmustine wafers and then chemotherapy. If the 3 patients, 3 have recurrence with this high PFS of 41.3, 39.3, 35.3 months, recurred now, indeed, we would have a median PFS of 17.1 months, which is quite high, and a median OS of 33.1 months. But of course, these results have to be considered cautiously. It's not an efficacy study, just a non-toxicity study. So just to remind you, the main goal of this study was the evaluation of safety. There were indeed non-acceptable or unexpected toxicity or serious adverse effects related to the addition of intraoperative PDT, neither clinically, nor radiologically, nor biologically. But of course, I hear most of you thinking, okay, does it work? Okay, I'm sorry, but this kind of study is not designed for such evaluation. But okay, I would like to show you 2 emblematic cases of the series. First, these 55-year-old patients, unmethylated, with this left temporal lobe glioblastoma, treated in May 2017. It was indeed the first patient, and she had a quite usual PFS of 9 months for unmethylated patient. But indeed, it was recurrence distant from the operative cavity in the left parietal lobe. And the operative field stayed free of recurrence until she died in January 2019. So that OS was of 20 months. Look at these patients, 70 years old, sorry. He presents all the bad prognostic factors of GBM. He is old, unmethylated. He presented loss of the chromosome 10, gain of the 7. He had an amplification of EGFR, and he was treated in February 2018 this left temporal glioblastoma and still free of recurrence in March 2021. So at the last follow-up, he had 37.7 months without recurrence, which is very intriguing. So here is an illustration of the operative theater during illumination for PDT. So you understand why protective glasses are required for everybody in the OR. So as a conclusion, we could consider the way we applied PDT with our medical device is safe and convenient for any team using FGAs. It's quite easy to use. Time of illumination is automatically computed. Moreover, it leads to an acceptable additional surgery time. But we have now to work on the best dose finding with the best balance, efficacy, toxicity in the way to achieve further pivotal study. So coming soon, we are now the authorization for our next clinical trial, dozen ago, for dose finding for intraoperative PDT for glioblastoma. We will do it in collaboration with Professor Florence Lefranc in Brussels, consisting in dose escalation up to 400 joules per square centimeter, 600 joules, and 800 joules per square centimeter. So indeed, we wished for the second trial a two-center study to spread the technique over another team. Moreover, so yes, let me show this graph showing that when you increase 4 times the dose of light, you never gain 4 times the penetration of the light. Indeed, with 8 joules by square centimeter, we will gain only 3, 4, 5 millimeters among the dose of 200 joules. Still in the idea to spread the technique, we had discussions with Kostas Agipanais now and his team. They will start at the end of the year the Indigo study in the US, still a safety study and feasibility of for the disposable pre-assembled light on specific laser qualified for the US will be available to consider their results. So at the end, it's important for me to present the team I work with. As neurosurgeon, I'm not an expert about light, laser, dosimetry, and so on. So Maximilien Vermandel, Clément Dupont, and Serge Mordon are my partners since the beginning of this work and very involved in the study's design, both at the preclinical and clinical levels. Nadir Adelem joined us to manage the immunological issue of the study, and obviously many other people. So thank you very much for your attention.
Thank you so much. That was really some amazing work. I was just wondering, with the cavities being different dimensions and sizes, do you use 1 or 2 balloons, or do you have balloons of different shapes, or how does it kind of accommodate for the different shapes and sizes?
No, it's a one-size balloon, but okay, you inflate it with less or more diffusing liquid to fit the margin of the cavity. But it's the same balloon for every size of cavity. Maybe in the future we'll have different size, but we start with a one-size device.
And does the final size match the volume of the tumor resected? Is that an important kind of characteristic, or is it just when it collapses on itself, it's just a matter of covering the surface area?
So you are very to inflate the balloon until you are close to the margin. Indeed, we push a little bit on the margin of the cavity to very be just close to the brain, and without blood between the balloon and the cavity, without other liquids that could block the light.
Mm. Yeah. Thanks, Dr. Rains. Yeah, that was really fascinating. A couple questions. Have you guys done an introp MRI with the balloon up to see how well it conforms to the actual surgical cavity?
No, we did not. Indeed, there is materials in the device not compatible with MRI. Indeed.
Yeah.
But in the future, with the next device, maybe it will be possible because there is no steels, only I think plastic. So it would be it's an interesting consideration.
Yeah, no, yeah, it certainly would be. Yeah, I mean, even in like a preclinical animal model, because we always have those kind of as Mike was saying, these kind of maybe complex surgical cavities that may not conform to kind of a straight round structure, and then you're going to end up with little pockets that aren't getting light that are then hiding tumors and maybe sites of recurrence. It would be interesting also in the future if when possible to like correlate that. Does that somehow correlate with regions of recurrence?
Yeah, I agree, and maybe an issue for understanding why there are different results between patients after PDT. Okay.
Yeah, that'd be really cool.
And the other thing is, your preliminary papers, which were also really great, show that there is, if you do serial laser or serial PDT, you could have an improved benefit. So was there any thought in the design of the trial to leave the balloon in post-op and treat on several days consecutively, or is it obviously there's risk of infection and whatnot, but I just want to know what your thoughts were on that.
Just when you start such study, I think you have to be the more safe as possible, and we wanted to do not modify the standard of care indeed. So the way we applied PDT did not impact the patient's quality of life. It's during surgery. It's equal for him, and we did not want to modify the way to treat the patients, and for later be in good condition to compare standard of care alone and standard of care plus PDT. But I think it's maybe a way of research, of clinical research in search of kind of metronomic PDT indeed, to repeat the illumination. Yes, for sure, it will be, but probably in further steps.
Yeah, I mean, that's kind of what strikes me is seems like such a promising avenue of treatment, right? To get that local disease, you're already using 5-ALA, and obviously future potential for other photosensitizers, but it seems very to potentially fall prey to something similar maybe that we've seen like in the endovascular world, where you spend time pushing through a study like this and show that there's some preliminary efficacy only for the technology to improve dramatically. And so that a failure of an early study like this doesn't necessarily mean that PDT isn't successful. It just may mean that we're not there with the technology.
For sure, I think there are many issues in the success of such or unsuccess of such therapy. So we had to start at the basics, I think, and to use what we know the best. So we know very well 5-ALA. We know it's very convenient for brain. It's have the authorization for be used for the brain. So it was easy to convince the regulatory agency to use 5-ALA for PDT. If we add another drug with another possible toxicity, I think we will have more problem to start the study.
Oh, absolutely.
I think in the future everything is possible, but we will have to have good basics, good basement for the further studies.
Oh yeah, and certainly kind of the work you're doing and some of the preclinical work has obviously made a huge kind of inroads there. So curious, because it gets to some of the things that Mike was bringing up when we were talking about in terms of where do you think the sonodynamic therapy kind of fits in, where it's not using light, but the idea being the same is that you're using 5-ALA as a sensitizer, sonosensitizer. Okay.
Sorry, I lost connection there for a second.
We got you back.
Yeah.
Yeah,
Sorry.
I was just asking Dr. Rains about if he had any thoughts on kind of where sonodynamic therapy, kind of using ultrasound that maybe gets to some of the points you were talking about of this kind of metronomic treatment or multiple kind of treatments over time, and if that thinks that might be either complementary or relative to kind of laser based, the photodynamic therapy.
It's a question for me. Sorry.
Oh yeah, I was just, yeah. I don't know. Kind of, I've just been kind of reading a little bit about some of the early work in the sonodynamic therapy using MR guided focused ultrasound and 5-ALA. I don't know if you have,
but I have very no experience with those techniques.
Yeah, no, either do I. It's more, kind of interested, kind of falls in a similar category or idea, but again offers the potential for I guess a non-invasive treatment that may be able to be delivered in that kind of metronomic or longitudinal way.
Good idea, I think.
Alexa, did you want to talk about a little bit of your work?
Yeah, absolutely. Let me share my screen here.
Just unmute yourself.
All right, there we go. Can everyone see my screen?
Yeah, looks good. Thanks.
So I wanted to present some of the work that I did while I was a research fellow in Dr. Ivan's brain tumor laboratory last year over a research year between my 3rd and 4th years of medical school. So we investigated new preclinical models for using 5-aminolevic acid photodynamic therapy for glioblastoma. And this we did in 2 settings. We did this in vitro in cultured cells, and we did this in a mouse model similar to what Dr. Rains was describing. So to give an introduction, similar to what was described before, 5-ALA photodynamic therapy for malignant glioma is supposed to work by administering this photosensitizing drug called 5-ALA, waiting for this drug to accumulate selectively in tumor cells compared to non-malignant tissue, and be metabolized by those cells into a precursor of heme called protoporphyrin 9, here PPIX. As described before, this PPIX has 2 important properties. First, it can be excited at certain wavelengths of light to give off fluorescence. So this is helpful for when we want to do fluorescence guided resection in the operating room. In this figure, we see that the tumor tissue is exhibiting fluorescence, allowing us to distinguish and get the best surgical resection that we can. And the second property that's important about protoporphyrin 9 is that it can be excited to produce free radicals that are going to cause necrosis and apoptosis. And you can see that I'm even borrowing figures from Dr. Rains' work, speaking to the impact that he's had in advancing this kind of work. So the evidence so far is that we know that extent of resection matters in terms of treating glioblastoma, that achieving a greater extent of resection confers a survival advantage. We also know that protoporphyrin 9 fluorescence has high sensitivity and specificity for tumor cells, meaning that it's going to accumulate in malignant cells and leave normal tissue alone. Finally, referring to some of the other preclinical studies that we were reviewing before, that 5-ALA fluorescence-guided resection has been shown to correlate with increased progression-free survival in glioblastoma patients, and that there are multiple preclinical studies that are showing that high-grade glioma cells are susceptible to this type of therapy. One issue that we wanted to focus on in the laboratory was focusing on the heterogeneity in the genetic landscape of these tumors. Multiple studies have shown that GBMs have different molecular markers, and even within the same patient, different recurrences can have different molecular profiles. So we wanted to, and previous clinical studies had shown that there are variable amounts of protoporphyrin IX fluorescence observed in tissue samples taken from different tumors from different patients. So this led us to the idea that variable protoporphyrin IX fluorescence after 5-ALA administration could lead to treatment resistance. So our research question was, does this heterogeneity in protoporphyrin IX accumulation across different GBM tissue samples create resistance, and what are some strategies for overcoming this resistance? We all started from the same beginning point, which is a patient diagnosed with glioblastoma. And we use the unique advantage of having access to the operating room and tissue samples from patients with these brain tumors. And we took those tissue samples and derived primary cell lines at the bench. We incubated these cell lines in 5-ALA or with a second drug that we thought might work synergistically with 5-ALA to sensitize these cells to photodynamic therapy. And then we treated them. We did 3 types of analyses based on this. We wanted to characterize the extent of protoporphyrin IX fluorescence exhibited by different patient-derived cell lines. We wanted to understand possible mechanisms underlying that variability in fluorescence by measuring the enzymes expressed along the protoporphyrin IX production pathway. And finally, we wanted to see the effect of this heterogeneity in fluorescence by treating these cells with a photodynamic therapy setup and measuring the viability afterwards. So we show here, this is immunofluorescence data of our patient-derived cell lines. We have 3 cell lines, GBM number 1, number 7, and number 12 here that are expressing characteristic glioblastoma cell line markers. In the left, we have a graph showing the results of 5-ALA administration in these different cell lines. So the different colored lines in this graph correspond to the 3 different patient-derived glioblastoma cell lines and a control normal mouse astrocyte cell line. And we measured using flow cytometry the degree of protoporphyrin IX fluorescence exhibited by all these cell lines with an increasing concentration when treated with an increasing concentration of 5-ALA in cell culture media. So we show that there are significant differences in the way these cell lines intrinsically accumulate protoporphyrin IX, even when treated with the same dose of 5-ALA. Next, we showed by using a laser photodynamic therapy setup that we built in the laboratory that when these cells are treated with photodynamic therapy, they are also killed to different extents. So, for example, GBM7, which is outlined corresponds to the red line, accumulated the least protoporphyrin IX fluorescence, and correspondingly, it also was least affected by photodynamic therapy. So this gave us the intermediate conclusion that high protoporphyrin IX fluorescing cells would be more susceptible to photodynamic therapy, whereas less fluorescing cells would be less susceptible. From this, we wanted to ask, how do we enhance the effect of photodynamic therapy in these lower fluorescing cell lines? Because this could help us overcome treatment resistance in these cell lines. To do this, we wanted to combine 5-ALA photodynamic therapy with a second drug, specifically a chemotherapeutic drug that's already FDA approved for use in patients with brain tumors, to see if they could possibly have a synergistic effect. So this experimental setup was similar to the last, but instead of just adding 5-ALA to culture media, we added 5-ALA and either temozolomide or carmustine, and then treated the cells with photodynamic therapy. On the right, you see the bar graphs represent the different treatment conditions that we treated these cells with photodynamic therapy doses in joules and second drug doses in micromolar concentration. And we show that combinations of photodynamic therapy plus a high concentration of the second drug caused more tumor cell death compared to drug or laser alone. And this is represented statistically on the right by these synergism graphs, where the dotted line on these graphs represents where our data points would lie if there was simply an additive effect between these two different therapies. Points that lie to the left of that line or below that line represent treatment synergism, i.e. a greater effect on cell death than one would expect from a simply additive effect alone. So in GBM7, we show that the combination of photodynamic therapy and a second chemotherapeutic drug actually confers synergism. Whereas in our GBM1 cell line, we didn't show as strong of a synergistic effect, as most of the points lie along that diagonal dotted line. So our summary is that protoporphyrin IX fluorescence does seem to correlate to some level susceptibility to photodynamic therapy, and that combination of photodynamic therapy with other chemotherapeutic drugs may be able to enhance the effect of photodynamic therapy. The last part of our laboratory work that we wanted to talk about was our preclinical model development. So our research question was can an animal model be developed to test serial delivery of photodynamic therapy to a tumor xenograft? And the reason why this question came up is because we were thinking about how to best treat tumor volume growing in a mouse without doing a surgical procedure that would disrupt the tumor tissue itself before treating it. To achieve this, what we wanted to do is build a fiber optic cannula that would be inserted at the same time that tumor cells were engrafted into the mouse's brain, so that the tumor could ideally grow around the end of this fiber optic cannula. Then at the time of photodynamic therapy administration, we would be situated above the tumor target and not require a second invasive procedure that could possibly disrupt tumor tissue. So on the figure here, we show that all the parts of our setup. We have a fiber optic cannula that's going to be embedded onto the mouse's head, and that can be connected and released from a fiber optic cable that'll deliver laser light. On the right lower corner of the slide, we see the schematic for the kind of surgery that this would entail. We would inject tumor cells into the mouse's brain, seeding an intracranial graft, and then position the fiber optic cannula to achieve the same target depth as the tumor cell injection. And then the fiber optic cannula would be situated on the mouse's skull and stay there. So this is to illustrate, this is an example of the surgical procedure that we did. We injected U87 glioblastoma tumor cells into a defined target in the mouse's brain under stereotactic guidance. And during the same procedure, we inserted this fiber optic cannula and secured it onto the mouse's skull. And then as the tumor grew, we confirmed tumor growth by using something called bioluminescence imaging. These U87 cells express luciferase, and we use this IVIS Lumina workstation to be able to image the tumor growth in these mice. Moreover, this workstation could be adapted to be compatible with our laser setup. So on the left, we have our laser box and our fiber optic cable feeding into the IVIS Lumina workstation. And on the right, we show pictures of the mouse. On the top, there is our mouse with the fiber optic cannula sitting on its head. And on the lower picture, we show how the laser interconnect can be attached to this cannula to deliver laser light to the mouse. The point of this was to be able to deliver photodynamic therapy directly to the tumor volume that's growing inside this mouse, and at the same time be able to image the tumor that is growing inside the mouse. So this is how, when we turn the laser on, that's what it looks like when we are delivering photodynamic therapy. And this shows, this graph shows the results of our initial experiment mapping glioblastoma tumor cell growth after 2 consecutive treatments with 5-ALA PDT. So compared to a saline control, mice that were treated with 5-ALA PDT had a lower tumor signal as measured by tumor bioluminescence compared to the control. So in vivo, we show that we have a preclinical mouse model in which we can grow an intracranial GBM tumor and a workflow by which we can treat that growing tumor volume with 5-ALA PDT. I just want to thank all the people who supported me during my research year in Dr. Ivan's lab, including Dr. Ivan, everyone else who was working there, as well as some of the neurosurgery residents who were there at the time that I was. And of course, the NREF and AOA Foundation for funding my research.
Thanks so much, Alexa. That was great, and obviously great work. Dr. Rains, any thoughts about what the future may hold with synergistic use of chemotherapies and timing of PDT, along with some of the other adjuvant therapies we have for glioblastoma? Do you think that's where it'll go eventually?
It's a question for me, sorry.
Yeah, just the future of combination therapy with the use of chemotherapy and radiation with PDT. And do you think that that's going to be kind of how it's going to work in the future, or do you think it's going to be as a more of a single line treatment kept separately?
Yeah, maybe to increase the concentration of PP9. So I think also that authors report the use of steel chelators indeed to increase the enzymatic deficit in the heme synthesis, also to increase the concentration of PP9. It's also a way to increase the PP9. And I have a question to Alexa Semanch. Okay, did you ever see GBM cell lines with absolutely no fluorescence?
I don't think we observed GBM cell lines that had no fluorescence, but we certainly had a wide range on a spectrum. We ended up investigating 4 different patient-derived cell lines. So we only have an N of 4 in terms of that. And in terms of other cell lines, we investigated U89 cell line, which took up a lot of protoporphyrin 9 compared to even the human-derived ones, as well as the mouse astrocytes. The mouse astrocytes were meant to be a control because since they are not glioblastoma tumor cells, they're just simple astrocytes, they should not accumulate protoporphyrin 9 anywhere near the extent of actual tumor cell lines. Despite that, they accumulated a little bit of fluorescence. So even control cell lines that are not representative of malignant tumor did accumulate protoporphyrin 9. Sorry, I'm trying to show the slide that shows this.
Yeah, we looked at some of the different importer and exporter enzymes that control the concentration of 5-ALA, and it was very tough to kind of draw a collaboration or a correlation between amount of enzyme or activity of enzyme and the fluorescence itself. One study, which was real preliminary, there was some question that maybe size of cell played some importance in the overall fluorescence, but that's, again, too little samples to really understand that.
Yeah, so in this graph, even our normal mouse astrocyte line in purple here accumulated some detectable amount of protoporphyrin 9 after 5-ALA. So I'm not sure if any cell line would accumulate nothing.
And did you see a correlation between the PP9 concentration and the time you deliver the 5-ALA? So because we saw that early we give the 5-ALA, the more we have a concentration of PP9. And so generally we deliver 5-ALA at least 6 hours before surgery, sometimes 8 hours. Not only 4 hours as recommended by the by MEDAC, the provider of Glioma. So we try to very give the 5-LA very early before surgery.
That's a good question. We did do an experiment where we studied the time for whether the time of incubation with 5-ALA would affect fluorescence. We did 6-hour, 12-hour, 24-hour, and 48-hour even time points. And we did find that I believe at about 24 hours, the effect plateaued. So incubation for longer than 6 hours may allow more protoporphyrin 9 to accumulate. But as you said, in an actual patient care setting, we would most likely be using the 6-hour before surgery time point because that's already approved and demonstrated to be safe. So that's also what we ended up going for all of the experiments with the data we show now.
I think 6 hours is a good time. And in our model, we wanted to have the same trajectory for the grafting and after for the insertion of the optic fiber. So we use a kind of anchor that we left on the skull of the rat, and by the anchor we graft the cells, and after we insert the fiber for 5-LA several days later.
I did read your study for that. It actually had we drew a lot of inspiration from your previous work, of course. I think what we were asking with our preclinical model was, if the tumor is already grown to a certain extent before the laser fiber is inserted, does the act of inserting the laser fiber do some kind of tissue damage that could be a confound for the effect of 5-ALA PDT? So we attempted to insert the laser fiber and the tumor cells all in one sitting, with a similar bone anchor that you had to actually keep the setup in place to allow the tumor to kind of grow organically with the laser fiber already in setting, to see if that could be an improvement to the model. I think it's a little less relevant in the sense that your current clinical study is occurring at the time where the tumor has already been resected. So you're treating the tumor cavity, which kind of eliminates this issue.
Great. Brad, any other questions?
No, yeah, that was super interesting to hear. I think this is a really exciting kind of area of investigation, both Dr. Rain's work and your and Alexis' work that I think is going to have a real kind of impact. So excited to see kind of where it goes next.
Great. Well, thank you again, everybody, for the time, especially Dr. Rains for spending late nights. I know it's very late over there. I'm sure you have a big day tomorrow, so we'll let you get some sleep. But I really, really appreciate it. And then hopefully we'll be in touch soon about some future projects.
Thank you very much for inviting me. Thank you very much.
Have a great night, everyone.
Goodbye.
All right, take care.